up to 35% women may have dyslipidemia. And imagine a girl of 16 years with dyslipidemia and impaired glucose tolerance and being obese and hyperandrogenic. Her chances of developing multiple problems in the future are obviously very, very high. Another problem which is missed is the association of this particular syndrome of PCOS with what is called the non-alcoholic fatty liver disease and NASH, which, as you know, is a problem of the liver which arises due to metabolic origins. And what it is really is that the liver shows inflammation because of fat which is ectopically deposited inside the liver. Normally, liver is the sort of workplace for all metabolic processes of the lipids, where fatty acids are incorporated into triglycerides and sent back. But instead of that happening, these free fatty acids get deposited into the periportal areas and causes inflammation, because free fatty acids are very inflammatory. And this causes this so-called steatohepatitis or NASH-like syndromes. And the problem is that NASH is now supposed to be believed to be the #1 cause of the so-called cryptogenic cirrhosis that we see in people. So what was labeled as cryptogenic cirrhosis, a large part of it could be actually non-alcoholic fatty liver disease. And the problem is like this, that if you look at ultrasounds, it is a sad thing that the radiologist will comment on top in a 18-year-old girl that the liver is laden with fat, the fat parenchyma is echoic, so on, so forth, and at the end, the conclusion will say a normal ultrasound abdomen. So that fatty liver is kind of passed off as something which is very common in fatty people. It is not so. It's actually a marker of NAFLD and the overall metabolic syndrome. What about CV risk? There is a clear reduction in the nocturnal dip in blood pressure in these patients. There is increased systolic and mean arterial pressures, an increase in the left ventricular mass index. All this is happening in young peripubertal girls. There is diastolic dysfunction, there is impaired endothelial function, and there is an increased risk, 1.5 times, of coronary events. And this was seen in what is considered as the largest long-term epidemiological observational study in women. That's the Nurses' Health Study in the UK, where thousands of nurses were followed up right from the day they entered nursing college, at that particular age, and they were followed up to retirement. So that entire lifespan was studied in a very stepwise manner for a lot of disorders. And here it was clearly demonstrated that they were at risk. Depression is more common because of a variety of factors. It could be because of the hirsutism and the irregular periods, but even having accounted for that, depression is still more common in these girls. Obstructive sleep apnea, which is again a metabolic syndrome and not just something related to the respiratory tract, is a common thing, and these girls often complain of lethargy all day, somnolence all day, and if you actually test, some of them may have obstructive sleep apnea even after controlling for their high BMI. So overall, it's a complex disorder. I'm not going to go too deep into pathogenesis. I'm just going to show you slides so that you are aware of what all this PCOS thing is about, and not just relegated to this FSH-LH ratio. It's a complex disorder. We don't really know how it occurs, but there are different genetic and environmental markers. So you must have some genetic marker to begin with, so that the environmental trigger sort of triggers it off. It still appears to be a disorder of ovarian steroidogenesis. So the primary fault still seems to be in the ovary, although there are a number of other things. There are a lot of genetic factors being studied, and probably, as I said, Dr. Yadnik might touch upon them, but essentially there is a familial risk as well. So if a mother has PCOS, the chances that her siblings and her daughters would have this is clearly there. It's an autosomal dominant. The transmission is from mother, and always in a family there is a clustering of risk factors like obesity, high risk of diabetes and metabolic syndrome. I'll skip this. I will skip this as well because perhaps Dr. Yadnik might cover it. And this is what I was talking about, that there is some evidence that adult insulin resistance disorders are actually programmed in utero because of certain abnormalities in the maternal environment to which the fetus is exposed. This could be a variety of things. This could be androgen, it could be insulin levels, it could be triglyceride levels of the mother, it could be folate and B12, number of things, because 7 out of 8 cell divisions of any individual actually takes place while in utero. So one can expect that a lot of programming actually occurs while in the womb. And what we see at the age of say 16 is just a reflection of what happened when the child was in the environment, in the uterine environment. So as I said, no single proposed explanation, number of them. Some say that it is because of altered LH and therefore hyperandrogenism. Some say it is insulin, some say it is ovarian. It's probably a mixture of all, and typically we don't know. This insulin theory has been long recognized in PCOS because insulin resistance, as I said, is a common feature of polycystic ovarian syndrome leading to type 2 diabetes. And I showed you earlier that PCOS and severe insulin resistance syndromes look alike. I showed you that picture of pseudoacromegaly. They look exactly similar. So it is perhaps likely that high insulin levels will cause a state which looks like PCOD. Moreover, insulin receptor defects have been noted in PCOS. And this is the whole insulin hypothesis. I'm not going to go into details of this, but what it means really is that insulin acts like LH and insulin acts through the IGF-1 receptors, basically stimulating the ovarian thecal cell hyperplasia, which then produces the increased androgen. So that's in a nutshell the insulin theory. There is something called the LH theory, which again, if someone is interested, I'll go back to because of brevity of time. But what I would like you to focus your attention now is we will take some tests of what we should do in PCOS. But there is something about what is called functional adrenal hyperandrogenism. Although we say that this disorder is typically of the ovary, you will find that 1/3 of patients have some degrees, subtle adrenal dysfunctions, and this may coexist with what is called functional ovarian hyperandrogenism. So when you have mild testosterone productions, we would expect that this testosterone is coming entirely from the ovary. But if you do some adrenal markers, say like maybe DHEAS or the 17-OHP, particularly the stimulated 17-OHP, you will find that there are mild abnormalities. So what this means is that the enzyme defects in androgen synthesis coexist in both the ovary and the adrenal. So that's what has brought about the idea that it is basically a problem of steroidogenesis in the ovaries and adrenal. So I will not go deep into this because it's not really in the topic of discussion today, but I just wanted you to know. So diagnosis, as I said, would be ovulatory dysfunction, essentially clinical diagnosis, mind you. But to prove ovulatory dysfunction, you already have irregular periods. There are various markers of ovarian function like ultrasonographic ovarian studies. You have these kits now to monitor ovulation, and you can do a serum progesterone mid-luteal if you have a regular period to find out if there is evidence of ovulation or not.